Thank you. This is another one of the topics I'd like to talk about, and as you mentioned, there's a lot of controversy about it, and hopefully we'll go over the different treatment philosophies and how I like to do things. So the first thing, we're going to review the features of the facet dislocations. Then we'll go a bit over the algorithm for initial management of the facet dislocations, followed by surgical decision-making. So this is the famous Allen Ferguson diagram where you kind of see the mechanistic injuries to the cervical spine. Generally speaking, facet dislocations are either a distraction flexion mechanism or a pure flexion mechanisms. Usually the more distraction you have, the more the facets are conserved, while when you have more of a pure flexion mechanism, you're more likely to have a facet fracture dislocation. And so when they jump, they could come in locked or perched. And so here you could see the diagram on the left. Those are the locked, and the one on the right is perched. The reason this matters is just in terms of kind of planning my reduction. The perched are a bit easier to reduce. Sometimes just hyperextending them will pull them back, while when I see fully jumped or locked facets, I know there's a good chance I'm headed for a closed reduction, and we'll talk about that in a moment. The other factor is when you have unilateral dislocations, generally speaking, you have up to a 25% vertebral body step off, as you can see here. And early when you have the unilateral dislocation, it's more of there's a rotational component to it, where it kind of hinges on the contralateral facet, which makes it inherently a bit more stable and doesn't allow it to advance, but also makes it more difficult to reduce. And so here you could see how the vertebral body translates approximately 25%. With either case, it's unstable injury. And then in the bilateral situation, you have about a 50% vertebral body step off, as you can see in the diagram over here. And then in that case, what happens is the cord gets stuck in between the vertebral bodies, and kind of like a cigar cutter gets pinched between the lamina and the vertebral body. When looking at the axial view, people talk about the hamburger and the reverse hamburger sign. So in this case, it's a case of a unilateral jump facet, and you could see how in the regular hamburger sign, the facets are articulating properly, and then on the left, you could see that they're jumped. And so, generally speaking, there's decreased space for the cord, which, depending on how patent the canal is and how much displacement there is, the patient may be intact or not intact or partially intact, but fundamentally, there's a failure of the posterior tension band in these cases. And so, in the examinal patients, both with deficits and also in my hands without deficits, the quickest way to decompress and stabilize the cord is with closed reduction in whether it be the ED or in our institutions, it's in the OR. However, in the non-examinal patient, where we do not know the status of the cord and we can't examine the patient, we would have to do an open reduction. And so the fear is that when we reduce the facets, there will be a herniated disc, and the patient will then have a further injury that we wouldn't be able to detect without an examinal patient. And so in those cases, I go straight to MRI to get more information. And so this is kind of my setup when I do my closed reduction. So in a patient who's intact or incomplete, in my end is examinable, the next step is an awake reduction. The moment you reduce those facets, the cord is no longer compressed. Now you've taken an emergent case and turned it into a more urgent case. So if this comes in the middle of the night, one is able to reduce the facets, take pressure off the cord, and now you could potentially do the case the following morning instead of getting the skeleton crew in the middle of the night. However, if the patient's obtunded, I take him straight to the MRI and then to the OR. One of the benefits of also doing the closed reduction is you could get the MRI and the CT with the cervical spine already reduced, and so that's also an aid for surgical planning. If you get the MRI with the patient dislocated, while you have an idea of what's going on with the disc, it's still not, you don't get as much detail as you do with the reduced spine. And so this is my acute workup. And so my first question when a patient comes in is whether the patient's awake or not, and whether they're examinable. If so, I immediately do an emergent closed reduction. Once I get that reduction, I then go and I get the MRI to see the status of the disc, and that helps me with surgical planning. If they're not awake and oriented, I take them to the MRI immediately. On the MRI, I check to see if there's an anterior disc herniation. If there is, there will be some kind of ACDF type procedure, whether in a standalone ACDF or ACDF that I back up. And if there is no anterior disc, I'll usually do a posterior fusion, though if the facets are competent, I think an ACDF is also an option. And so when reducing your jump facets, you want to start by distracting. And then after you get, and then just like any other fracture, we know you want to make the injury, you want to replicate the injury in order to unlock the facets. And so you want to put a bit of flexion to recreate the injury so you could unlock the facets from each other, continue with more distraction. And a little pearl of wisdom is when I put my Gardner-Wells tongs, I actually put them a bit more posterior because that allows me to have a bit more of a flexion arm and unlock the facets. And so that's an aid. And so, and also I make sure that the rope is pulled in a flexion type of moment. And then you pull more distraction. And then once you get it out to length, you then extend, put it back in, lock the facets, and now the spine is stable if the facets are intact. If it's a fracture dislocation, I'm a bit more concerned because it could theoretically translate some more. So after a successful reduction, I go ahead and get an MRI to assess the cord for an anterior disc. And so once you have a reduced spine, you could then choose your approach of anterior, posterior, both, and whatnot. And so the pros for going anterior is you have less concern for positioning an unstable C-spine patient, and this could also be favorable in a polytrauma patient where prone positioning is a concern. However, if closed reduction is unsuccessful, then you have to reduce the facets indirectly. In addition, it doesn't address the tension band failure. However, if the facets are competent and not fractured, they do provide a good buttress for translation. The pros of going posterior: you address the tension band failure with posterior instrumentation. You can directly unlock the facets if the patient's still dislocated. The cons include positioning considerations. In addition, if you have a bit of an incompetent facet, you may need to do additional levels of fusion. And so here in this slide that's looked at the traumatic unilateral and bilateral facet dislocation treated with anterior cervical discectomy, they showed that they had a low failure rate. So they looked at 36 patients who were treated with ACDF using a fixed locking plate, and there were 3 treatment failures in total. All had associated end plate fractures, and one had an associated facet fracture. And 43 patients with end plate fractures as a whole failed with an anterior construct alone. And so what we learned from that is you could do an ACDF if you have competent facets and if you do not have an end plate fracture. Now, what to do? Now, let's take the situation of an unsuccessful closed reduction, or if the patient is obtunded, and so now you need to do an open reduction. And so here we have our joint facets, and if I'm trying to reduce this anteriorly, what I'll do is I'll take the Caspar pins and I'll actually put them convergent, as opposed to when we do a standard ACDF, you kind of want to put them divergent to open up the front. Here, by putting them in this position, when you reduce the Caspar pins, you actually end up opening the facets in the back, and that gives you that distraction and kind of helps reproduce that flexion mechanism to unlock the facets. And then once you get your reduction, you could then converge them, and voila, you have a reduced facets. And so after you've brought them down, you may then want to replace them for the discectomy itself, depending on whether they're underway or if you want to bring in that lordosis. Now, when looking at open posterior reduction, there are a number of ways one could do this. Generally speaking, here we've got our joint facets again, and it's just usually amenable for direct reduction once the lateral maskers are placed. You may consider removing the subarticular process of the caudal segment. And so, as marked over here, and so the options are either you could pull it out to length and bring them over, but if that doesn't work, you could just shave down the superior articular facet and then slide it over. And so, kind of looking at my approaches of anterior, posterior, if I have a facet dislocation with an end plate compression, there's definitely going to be a posterior fixation component to it, with or without an anterior component. The ACDF will be performed if there's a disc, and then I'll back it up with a posterior construct. If there's a facet dislocation with no end plate compression, you get the MRI. If you have a retropulse disc, the patient's definitely getting an ACDF with or without a posterior portion. And if there's a no retropulsion of the disc, it's dealer's choice with an ACDF or a posterior fixation. Again, if the vertebral body is intact and if the facets are somewhat competent. So now let's just go through a couple of cases. So this is a 30-year-old male who presented the ED after a 20-foot fall with a GCS of 14, blood pressure in the 80s. CT was negative, and the blood pressure improves with fluid. And so, as you can see, he has some deficits. He has paresthesias at the level of the clavicle and below. He has decreased cessation altitude S1, and he's rectal intact. And so, let's play this video. Okay. And so, as you could see over here, this patient has a unilateral facet dislocation. And again, with the unilateral facets are a bit harder to reduce, and so you also, when you reduce these, you also want to do a little bit of a rotational component to clear that facet. And so this patient was taken to the OR for a way closed reduction on an ED gurney. After that was done, you get an MRI to assess the cord, and then you do a decompression infusion. So again, the setup kind of looks like this. You get anesthesia on board to kind of give the patient some anxiolytics and analgesics, but not so much that they're not examinable. You place the Gardner-Wells tongs. You tape down the shoulders, because inevitably these injuries tend to be around the cervicothoracic junction, and it's hard to view that area. And I initially just put 5 pounds to assess for a hidden AOD, and then I proceed. Again, ensure that the head is in flexion when I do the reduction. And kind of the two tricks I do to put in flexion is I put the bar elevated up to kind of put a flexion moment. And if you look at the red circle on the left over there, we put an A-line bag that could be inflated. And the reason we do that is so that after we get the reduction, we're able to extend the patient without having to lift the scapula and put the bump in. And so we gradually increase the weights and then do motor and sensory examination after each time we add the weights. And so here in this example, you have the jumped facets, and you can see we're adding more and more weight. And once it's out to length, we hear the click, it gets reduced, or we feel the click. And then now we want to put them in extension to stabilize the spine. And so that's when we inflate the A-line back to get hyperextension and lock them down, which you could see in this video over here. And so now the neck is extended, and now it's kind of dealer's choice if you want to go straight to the OR right now, or you could wait till the following morning because you've essentially decompressed the spine. However, in this patient, you could see that there's still ongoing compression, and so we decided to take him immediately to the OR. You can see that at C4-5, there's some cord hemorrhage with cord signal changes, and the other levels are looking kind of snug as well. And so when managing this case, we actually decided to go a bit further up and down so that we could get a full decompression of the cord, and also because we anticipated secondary swelling. And so this patient ended up getting a C2 to C6 PSIF with decompressions from C3 to C5. And here you could see the postoperative MRI where you could see a nice complete decompression as compared to the pre-op MRI. And so he continued to do better postoperatively and was discharged to an acute rehab. The second case I have was actually an interesting case. This is a 54-year-old male with a history of being a T7 Asia A back in his 20s who fell out of bed during one of his transfers and jumped facets. And so he had an incomplete cord injury. And this patient especially, he was very dependent on his upper extremity. He already had a previous injury. And so I closed reduced this patient. And you could see over here, it's relatively decompressed. But if you look down at the C6, C7 level, there may be a bit of a hematoma over there compressing the cord anteriorly. In addition, with this patient being wheelchair bound due to his previous injury, these patients constantly lean forward and really exercise their upper extremities. And so I kind of wanted to make him somewhat bulletproof. And so I ended up doing a front back on him, decompressed the front, and I could have probably finished with just an ACDF alone, but due to his increased activity being wheelchair bound and everything, I opted to reinforce it with a posterior construct as well. And so when encountering these injuries, it's important to have a plan in mind for facet dislocations, closed reduction only in an awake and examinable patient. An ACDF should be done whenever you have anterior compression, and then that could be augmented with posterior fixation as well. However, if you're going to do a standalone ACDF, the end plates have to be competent, as do the facets. And at the end of the day, you decompress what is compressed. Thank you.
David, one question that was really nicely done and very systematic. In this era, should we still actually teach algorithms of how to do a closed reduction and how to contemplate MRIs? At the last couple of spinal cord injury knowledge forum meetings with Michael Failings and Brian Kwan, all sorts of people there, the general thought was we should now have enough credibility in our ORs that we raise the patients to the ORs and do an open reduction from the front to take away that whole discussion about disc herniation or not, and just do an anterior open reduction ASAP. So why would we not do that?
Well, I mean, because it's potentially an unnecessary approach. The end plate may have problems with it, and the patient may just not need an ACDF. And so when doing and you may also have an unsuccessful reduction anteriorly. And so generally speaking, when I address these injuries, I like to approach them from a posterior approach, and I need an indication, whether it be increased demand by the patient or the disc, to do the ACDF. I just think the posterior approach is the workhorse. But honestly, one thing that I've been wondering about is we're constantly afraid of kind of doing a closed reduction, and essentially you're pulling the disc out to land. You're pulling the disc height out, and then you're bringing it over. But when we do an open reduction from a posterior aspect, we're usually just kind of dragging it along. And so I almost wonder if that's causing more shear along the disc than a closed reduction.
Bob, what did you teach at Jackson? Is that still the norm? Get this whole algorithm going? Have a striker frame with a reduction bed and a fluoro suite?
I think if you can go immediately to the operating room, I love that aspect. Problem is that you can get a little bit of a delay. I like to get the spine reduced. I mean, if you do an indirect decompression, then or if you reduce it, you're doing an indirect decompression a lot of the times, and you'll take all that pressure off. So, I'm still a firm believer of making an attempt to reduce it acutely. Again, the sooner you can do that, then if you realign the spine, then you've got the pressure off the cord. And I like your concept of distracting out, because I think that there is some truth. So ligamentaxis that we have, as far as being able to bring those soft tissue structures back into play, and so it decompresses the canal, gives you a little bit of extra time. So yeah, I'm a firm believer in immediate reduction if at all possible. And I love the Gardner-Wells tongs.
Yeah, another point is I'd rather have an MRI of a reduced spine than a dislocated spine. It's more informative.
That's my point. We should not even have MRIs of dislocated necks anymore. Memorial Hermann, how's that going? Do you get enough clout that you can just get into the OR and reduce it?
Yeah, if I know I'm going to the OR anyway, I reduce it in the OR. I treat these very simply. If I'm going to the OR and I want to reduce them, and I want to reduce them quickly, then I'm going to the operating room right then and there. Whereas otherwise, I don't like. It's not a waste of time to reduce closed, but again, if the end game is the OR, just get it done in the OR.
Jens, how many times have you not been able to reduce a junked facet?
So we actually published on it with Andrew Daly, who's usually the course co-chair here, and it is very rare. We actually had 83 consecutive reductions. The biggest biggest struggles we had is delayed reduction. So patients who came from Yondersville and were unreduced and have severe muscle spasms are big guys. That's a problem. Those Alaska transfers from Palmer or something like that.
And especially if they're like unilateral.
Yeah, that's a hard sell. But what we learned there is actually that usually you don't have to get a full reduction. If you just get the canal decompressed and the spine somewhat realigned, even 20 pounds is enough, and then just get them into the OR. So rather than putting some heroic weights on there and switching from titanium to stainless steel tongs and back again and sending the intern out for more weights and starting to do chiropractic maneuvers, which is really a no-no. Just get the spinal canal realigned, get them going. The other thing, this is a logistics question to you, is when you have them reduced, what do you do when you want to get the MRI scan done? This is still a little bit of a problem. There's a certain place that's not too far away from here where an MRI scanner was nuked by a sandbag that was brought into an MRI scanner with a patient still in traction. So what do you do after you have a reduction, you want to get that MRI scan with a patient who's not fixed yet?
So the scenario is the patient's reduced, going to go with the MRI. So usually the big issue I have is they don't want me to put the metal Gardner-Wells tongs on. So we do have MRI compatible Gardner-Wells tongs. So we'll sometimes just switch them into those for the MRI while someone's pulling. But I agree.
We had a well-publicized blow up there, and it's amazing what destruction a sandbag can do in an MRI scanner. It's truly dramatic. So this is a lot of hassle. So for us, we're not a trauma center. We have no trauma center rating here. We routinely get a couple of facet dislocations a year. I don't know how they come in here, but they come in here, and we literally have actually gained enough clout with the OR that we can just get them into the OR ASAP. So magic happens, and then it's actually quite nice. And we've not found any big problems going from the front. I've had one patient I distinctly remember at Harborview. I just could not get him back. We did a discectomy in the front, and with all the tricks, I could not do it. And I flipped him around, drilled off the facet joints, reduced him, and then put a plug in the front. Turned from a 2-hour case into an 8-hour case.
No, absolutely. And I think you could definitely reduce them from the front, but I think that also requires a bit more experience. And I think for the orthopedic surgeon who doesn't see these as often, it's a bit more straightforward to do it from the back if you're going to do it open.
The technical point I'd like to add is bicortical pins, well placed, and if you have a unilateral facet, put them in line of the axis of the vertebral body so you can get a derotation effect.
Yeah, absolutely.
And having an intervertebral spreader available and being relatively fast with your reduction. Great talk. Final talk, Ashraf, AOD. Thank you, David.